Differential diagnosis. When a patient over 50 years of age complains of nocturnal frequency of urination, we mentally set him down as a prostatic. Yet the inference is by no means strict. Surely 2 out of 5 cases of nocturnal frequency are due to other causes, such as nocturnal polyuria, prostatic carcinoma, or urethral stricture. The average prostatic begins to suffer between 55 and 65 and first consults a physician at about the latter age. The patient who does not begin to suffer until after he is 70 years old usually has carcinoma. Moreover, it is not to be forgotten that occasionally prostatic retention occurs in young men 20 or 30 years before the prostatic age. Careful physical examination rules out such conditions as stricture and nocturnal polyuria, but 4 conditions causing the symptoms of prostatism are very commonly confused. Indeed, it may for a long time be difficult in a given case to make the diagnosis absolute among them. These conditions are prostatism, adenomatous or sclerotic, prostatic neoplasm, paralysis of the bladder, prostatic calculus. Prostatism may usually be distinguished from the other 4 as follows. Prostatic neoplasm. To distinguish prostatism from prostatic neoplasm always requires careful rectal examination, sometimes cystoscopy, and occasionally the test of time, page 315. Spontaneous hemorrhage is suggestive of prostatism rather than of malignancy. Paralysis of the bladder. When there is retention of urine, but no urethral stricture and no palpable prostatic enlargement, the following possibilities must be contemplated. 1. There may be paralysis of the bladder. This is commonly due to tabes, shows a rather suggestive cystoscopic picture, and is distinguished by the reflex changes and the examination of the spinal fluid, page 469. 2. There may be carcinoma. Careful palpation then reveals nodules and a thickening of the posterior lobe. 3. There may be a pedunculated middle lobe or a bar, visible by cystoscopy. 4. Rarest of all and oftenest in relatively young men, we encounter the type of sclerotic prostate that shows no characteristic change to cystoscopy or to rectal touch. The existence of this condition can only be affirmed after tabes has been excluded by the most rigid tests. Prostatic calculi. Inasmuch as prostatic calculi may give no subjective symptoms at all, or may produce only a vesical irritability, while for objective sign they cause enlargement of the prostate, it is quite possible to mistake calculi for prostatism. Yet I have not known this to be done. Indeed, the irregular outline of the prostate, containing many calculi, is usually such as to suggest neoplasm rather than prostatism.